Imagine you're standing in the neonatal intensive care unit, right? You've just pushed a dose of life-saving surfactant into a premature infant's endotracheal tube.
Right, which is incredibly stressful already.
Oh, totally. And then suddenly you hear this thick, wet rattle coming from their airway. And I mean, every single instinct in your body, every basic life support class you've ever taken is just screaming at you to grab the suction catheter and clear that airway.
Yeah, of course, that's the reflex.
But if you do it right now, you might just strip away their only chance at survival. So welcome to the counterintuitive, incredibly high-stakes world of pediatric nursing.
It really is a specialty that completely rewrites the rules. I mean, pediatrics isn't just, internal medicine for tiny adults. Their physiology is entirely different.
Yeah.
Their baselines are constantly shifting because they're rapidly developing, and very often, your patients literally do not have the vocabulary to tell you what hurts.
Exactly. And right now, you, the dedicated nursing student listening to this deep dive, are probably staring down a mountain of textbooks, prepping for your ATI RN pediatric nursing proctored exam.
And honestly, it probably feels completely overwhelming.
Oh, absolutely. Because you're looking at a diagnostic landscape that is complex, it's moving fast, and it's full of hidden traps.
Which is exactly why we're here. We're going to help you navigate those traps.
That's the whole mission for this deep dive. We are your ultimate study shortcut. So we're looking specifically at 3 massive, highly testable chapters from your ATI Proctored Review and the RN Nursing Care of Children textbook.
Right, so that's Chapter 42 on complications of infants, Chapter 43 on pediatric emergencies, and Chapter 44 on psychosocial issues.
We're going to cut straight through the dense textbook jargon and highlight the exact clinical manifestations, the priority nursing actions, and the actual mechanisms behind them.
Because just memorizing facts might, get you a passing grade, but understanding why these things happen is what will make you an incredible nurse.
Yeah, because on the floor and on this exam, you don't just need to know what a condition is called. You got to know exactly how to respond when every single second counts.
Let's start this narrative where life itself begins. Before a pediatric patient ever reaches a schoolyard or an emergency room, they face these really profound physiological vulnerabilities right out of the womb.
Yeah, Chapter 42 covers complications of infants, and the test writers absolutely love neural tube defects. Okay, let's unpack this specifically, a condition called myelomeningocele.
Yeah, that's a big one.
I look at this word, and it is a mouthful. From a clinical perspective, what exactly are we looking at when a baby is born with this?
Well, you're looking at a profound failure of the neural tube to close during embryonic development. Visually, a myelomeningocele presents as a sac-like cyst protruding right through a defect in the infant's spine.
Right.
But it's what is inside that sac that makes it a critical emergency. It contains meninges, cerebrospinal fluid, and an actual portion of the spinal cord and nerves. So the central nervous system is quite literally exposed to the outside world.
Wow. To help me picture this for the exam, I like to think of the myelomeningocele sac as a highly fragile, life-sustaining water balloon attached to the baby's back.
That is a great visual.
Yeah, and it must never, ever bear weight. That means you have a super rigid positioning requirement. The infant has to be placed in a prone position, so flat on their stomach, with their hips flexed and legs abducted, you can never cuddle this baby on their back, period.
Exactly. And that water balloon has to be kept perfectly hydrated. The highly testable nursing action here is to apply a sterile, moist, non-adhering dressing using 0.9% sodium chloride.
And here is where the exam loves to test your clinical judgment. Let's say you're checking on the infant and you notice that the sterile dressing has completely dried out.
Oh, this is a classic trap.
Right. Because wait, hold on. My basic nursing instinct says if a dressing is dry and stuck to a wound, it's a massive infection risk. Or it's dirty. Why wouldn't I just carefully peel it off and put a fresh, clean one on?
Because if you do that, you might cause a fatal complication. If you pull a dry dressing off that sac, the friction is highly likely to tear the delicate tissue.
Oh, wow.
And if the sac tears, you cause a catastrophic leak of cerebrospinal fluid, and you open a direct highway for bacteria into the spinal cord, which leads to meningitis. So if the dressing is dry, you do not remove it. You simply add more 0.9% sodium chloride to remoisten it right where it is.
Just keep the balloon wet. Got it. Now, because these infants are going to undergo multiple surgeries and complex medical procedures very early in life, they're exposed to a lot of medical equipment.
Which means a lot of latex.
Exactly. This puts them at a massive risk for developing a latex allergy. And the exam loves testing cross-reactivity, so you have to link that latex allergy to specific foods.
Right, the food connection is crucial.
If the child is allergic to latex, you gotta watch out for bananas, avocados, kiwis, and chestnuts.
And if we connect this to the bigger picture, anytime you have a structural abnormality involving cerebrospinal fluid, you have to be constantly vigilant about increased intracranial pressure, or ICP.
Right.
For these infants, you aren't just looking at the sac on their back. You are constantly measuring their head circumference and gently palpating their fontanelles to see if they're bulging. That's a key early indicator that fluid is backing up into the brain.
Let's shift our focus from the nervous system down to the gut. Another massive neonatal complication is necrotizing enterocolitis, or NEC.
Yeah, NEC is incredibly serious.
It's an inflammatory disease of the gastrointestinal mucosa, and we usually see it in premature infants. The textbook says it's caused by GI ischemia or hypoxia, but how exactly does a lack of oxygen destroy the bowel?
It's a fascinating, albeit tragic, physiological triage. When a premature infant experiences a severe lack of oxygen, maybe from birth asphyxia or struggling to breathe, the infant's body goes into pure survival mode. It realizes it only has a limited amount of oxygenated blood, so it actively shunts blood away from non-essential organs like the gut and redirects it to protect the brain and the heart.
So the gut is basically sacrificed to save the brain.
Exactly. And because the intestinal tissue is deprived of that vital blood flow, it literally begins to die. It necroses.
Which explains the clinical manifestations you need to memorize. When that tissue dies, peristalsis stops. The gut isn't moving, so if you're feeding this infant, the food has nowhere to go. It just sits there.
Right, which leads to gastric residuals.
Exactly. The dead bowel can't process the formula or breast milk, so it backs up into the stomach. You'll also see a severely distended abdomen and bloody stools. But the diagnostic red flag, like the thing that will definitively pop up on your exam, is what the abdominal x-ray looks like.
Yes, the soapsuds appearance.
Right. It shows a characteristic soapsuds appearance of the intestinal wall.
That soapsuds visual is crucial to understand. It's actually air infiltration. Because the tissue is dying, bacteria are having a field day, and they're releasing metabolic gases straight into the compromised wall of the intestine.
Wow.
If you see that on an x-ray, or if you even suspect NEC based on abdominal swelling and bloody stools, your very first nursing action is to stop all feedings immediately. The infant goes NPO. You have to rest that gut.
You'll also need to insert a nasogastric or NG tube for abdominal decompression, basically venting out that trapped air and fluid. And to track how bad the swelling is, you need to measure the infant's abdominal girth every 4 to 8 hours.
And there's a specific technique for that measurement, right?
Yeah. The testable technique here is that you measure just above the umbilicus, and you must mark the infant's abdomen with a pen. Why? So that when the next nurse comes on shift, they're measuring in the exact same spot. A millimeter of difference matters here.
Precision is absolutely everything. Which brings us to the scenario you mentioned at the very beginning of the deep dive. Respiratory distress syndrome, or RDS. This is arguably the most common complication of prematurity.
Right, and it all comes down to a substance called surfactant. I like to think of surfactant as a microscopic soap that coats the inside of the lungs.
That's a good way to put it.
Its job is to reduce surface tension so that the little air sacs, the alveoli, don't stick together and completely collapse every single time the baby exhales. Premature babies simply haven't been in the womb long enough to produce their own surfactant.
And without it, every breath is a monumental physical struggle. The alveoli collapse, and the infant has to use immense force to pop them back open.
Which looks awful to witness.
It does. This leads to the classic manifestations of RDS tachypnea, which is a respiratory rate greater than 60 breaths of minute expiratory grunting as they try to force air against a closed glottis to keep the lungs open, severe nasal flaring, and fine crackles when you listen to their chest.
So to treat it, we literally have to manually give them the soap they're missing. Medications like Baractin or Paractin alpha are synthetic lung surfactants, and they're administered directly down into the infant's endotracheal tube.
Right.
But the post-administration protocol is a massive trap for nursing students.
What's fascinating here is the absolute rigidity of that nursing action. After you administer Baractin down the ET tube, you must avoid suctioning that tube for 1 full hour.
1 full hour?
Yes. As you noted earlier, Your nursing instinct, especially with a tiny neonate who sounds like they're drowning in fluid, is to grab a catheter and clear the airway.
Mm-hmm.
But you have to understand the physics of what you just did.
You just poured a heavy liquid medication directly into the lungs. If you suction too soon, you aren't clearing harmful mucus. You're literally vacuuming out the life-saving medication before it has a chance to coat the alveoli.
Exactly. You have to fight your own reflexes to save the patient.
It requires immense clinical discipline. Okay, so let's transition. Let's say we've done our jobs perfectly. We stabilized the delicate neonate, rested their gut, and kept their lungs open. Time passes. The infant grows into a toddler.
And toddlers get into everything.
Oh, yeah. They start walking, climbing, and putting everything in their mouths. The threats they face completely evolve. The internal vulnerabilities of birth are replaced by external sudden crises, which means our nursing priorities shift drastically. Welcome to the emergency department in Chapter 43.
This is where we leave the slow burn of developmental complications and enter the realm of acute, sudden trauma. In pediatrics, respiratory emergencies are the #1 reason a child codes.
Really?
Yeah, their airways are smaller, their immune systems are naive, and they compensate differently than adults do.
And the ATI exam is absolutely notorious for trapping students on the physiological difference between early and late signs of respiratory distress. You have to know the cascade of how a child crashes.
It's all about compensation versus failure.
Right. Early signs are all about the body fighting a war to compensate. The brain senses it isn't getting quite enough oxygen, so it hits the panic button and dumps adrenaline.
Which is why the child looks like they're running a marathon while sitting perfectly still in a hospital bed.
Exactly. The adrenaline causes restlessness. Restlessness is a huge, highly testable early red flag. Never ignore a child who suddenly can't get comfortable.
Absolutely.
Alongside that restlessness, you'll see tachypnea and tachycardia. So the lungs are breathing fast to pull in oxygen, the heart is pumping fast to deliver it, and diaphoresis, meaning they're sweating profusely.
But a toddler's body only has so much energy. Eventually they run out of reserves, and this is where the mechanism shifts from compensation to failure. The heart muscle itself becomes hypoxic. It is starving for oxygen.
Which is terrifying.
It really is. That's when you cross into advanced hypoxia, or the late signs.
Late signs are scary because everything that was fast suddenly becomes slow. The child goes from fighting to giving up. You see bradypnea, dangerously slow breathing. You see bradycardia, the heart rate plummets. The skin turns blue, which is cyanosis, and they slip into a stupor.
Yeah.
If a child who was just thrashing and crying suddenly becomes quiet, blue, and their heart rate drops, they aren't calming down. They are crashing.
And one of the most immediate, terrifying causes of that kind of respiratory distress in toddlers is an airway obstruction, choking. The exam is very strict about how you intervene, and the protocol is entirely age-dependent.
Right. For infants under 1 year of age, you use a specific combination of back blows and chest thrusts. But the moment they graduate to being toddlers or older children, you switch to abdominal thrusts, commonly known as the Heimlich maneuver. Now, what about reaching in to grab the object?
There is a major nursing absolute here that you must drill into your memory. Never, ever perform a blind finger sweep.
Why? I mean, if I know something's in there, shouldn't I try to fish it out?
Because of the anatomy of a child's airway. It's shaped like a funnel. If you sweep your finger blindly into a panicked, thrashing toddler's throat, the anatomical reality is that you are almost certainly going to push that object deeper, wedging it firmly into the narrowest part of the airway.
Oh, geez.
Yeah, you only sweep if you can vividly see the debris and can easily hook it out. Otherwise, stick to the thrusts.
Here's where it gets really interesting, though. Let's talk about poisoning. I have a question for you. If a toddler manages to climb onto a counter and swallows an entire bottle of pills, the instinct of every parent in a movie is to immediately force them to throw it up.
Yep, the classic movie trope.
Right. So why is syrup of Ipecac a huge definitive no on the nursing exam today?
It's a fantastic question because the protocol completely reversed over the last 2 decades. We used to induce vomiting, but the data showed it was incredibly dangerous. Think about the mechanics. First, if the poison was a caustic chemical, like bleach or drain cleaner, it burned the esophagus on the way down. If you force the child to vomit, you're pushing that highly acidic or basic substance back up, burning the delicate tissue a second time, potentially rupturing it.
Oh, wow. That makes sense.
Second, a child who is forcefully throwing up is at a massive risk of aspiration. They take a sudden breath, and they inhale that toxic vomit directly into their lungs, causing secondary chemical pneumonia. So inducing vomiting is entirely contraindicated now.
So the clinical focus has completely shifted to neutralizing the toxin chemically or binding it up in the stomach so the body simply can't absorb it. And the exam will mercilessly test you on matching the specific poison to its exact antidote.
Yes. For example, if a child overdoses on acetaminophen, which is Tylenol, the specific highly effective antidote is a medication called N-acetylcysteine, which is given orally.
But if they overdose on acetylsalicylic acid, which is aspirin, the treatment pathway is completely different. For aspirin, you administer activated charcoal or you perform a gastric lavage. I like to think of activated charcoal as a massive molecular sponge. It doesn't destroy the aspirin, it just traps it in its porous structure. So instead of the intestinal walls absorbing the toxic aspirin into the bloodstream, the sponge holds onto it and the child just passes it safely in their stool. You have to deploy the exact right countermeasure for the specific toxin.
Precisely. Before we leave the realm of acute, life-threatening emergencies, we have to touch on prevention, specifically SID, sudden infant death syndrome.
The Safe to Sleep ChemPIGR guidelines are heavily tested. It sounds basic, but you need to know the exact parameters. Infants must always be placed on their backs to sleep, never on their stomachs or sides.
Never.
They need a firm mattress. There should be 0 pillows, no quilts, no bumper pads, and absolutely no stuffed animals in the crib. You also want to avoid overheating them with heavy blankets. But the one that always surprises people, offering a pacifier at naps and at night, actually reduces the risk of SIDs.
It seems minor, but the mechanism is important. Sucking on a pacifier keeps the infant in a slightly lighter state of sleep, preventing them from falling into a dangerously deep sleep where they might forget to breathe.
Oh, interesting.
Yeah, it also physically helps keep the tongue forward and the airway open. It's an incredibly simple, high-yield intervention to educate parents on before discharge.
Okay, so we fixed the lungs, we've neutralized the poison, we've secured the airway. But what if the greatest threat to a child isn't a physiological failure or an accidental poisoning?
This is where it gets tough.
Yeah. What if the threat is the caregiver themselves or a stall in their own neurodevelopment? Treating the physical body isn't enough. We have to look beyond the physical to the psychosocial environment and the hidden traumas that children endure. That brings us to our final source, Chapter 44.
This is universally considered the heaviest, most difficult part of pediatric nursing. Because you aren't just assessing a patient in a vacuum, you're assessing a deeply complex family dynamic.
Let's talk about maltreatment and abuse. The warning indicators are highly testable. As a nurse, your biggest red flag is an inconsistency between the caregiver's report of what happened and the child's actual physical injury.
Always listen to the story.
Right. If the parent's story keeps changing, or if the story simply defies the developmental laws of physics, like a 3-month-old infant supposedly rolling themselves off a high kitchen counter, your internal alarms need to be ringing.
And there is specific, undeniable physical evidence that you need to be able to identify on site. For example, burns. A glove-like or stocking-like burn on the hands or feet is a massive red flag.
Because it indicates forced immersion. If a child accidentally pulls hot water onto themselves, the water splashes, right? You see irregular, sporadic burn marks.
Exactly.
But a glove-like burn creates a perfect solid line around the wrist or ankle. That only happens if a caregiver forcefully holds the child's limb submerged in scalding water and the child is physically unable to pull away. You also need to look for small, perfectly round burns, which are typically from lit cigarettes being pressed into the skin.
And then there are the bone injuries. The exam loves to ask about spiral fractures of the forearm or the femur.
Right, let's look at the physics of a spiral fracture. A normal childhood break from falling off a swing set is usually a clean, horizontal snap. But a spiral fracture looks like a corkscrew winding around the bone.
Which is very specific.
Yeah, that doesn't happen from a simple fall. A spiral fracture is created by extreme, forceful twisting of the limb. So if you're in the ER and you see that perfect glove-like burn, and you see the X-ray with a spiral fracture, and the caregiver's story makes absolutely no sense, do you investigate first? Like, do you confront the parent and demand the truth, or do you report it immediately?
This raises an important question, and it is a massive ethical and legal boundary that the exam tests strictly. Your priority as a nurse is always, unconditionally, to have the child removed from the abusive situation.
Right.
You are a mandatory reporter. That is a requirement by law. But, and this is the trap, your job is not to interrogate the parents, secure a confession, or play detective.
So what exactly is the nursing action?
Your job is to document the facts objectively and report those facts to Child Protective Services immediately. You note the bruises and categorize them by their exact stages of healing, which proves a timeline of abuse.
That's just the facts.
Yes. You describe the exact measurements and shapes of the burns without writing down assumptions about the weapon used. You document and you report. You do not confront.
Document objectively, report immediately. Got it. Now, another profound psychosocial issue that can stem directly from a child's environment is failure to thrive, or FTT.
Yeah, FTT is very complex.
It can be organic, meaning there's a physiological medical cause like a congenital heart defect that is burning too many calories. Or it can be non-organic, meaning it's an environmental, nutritional, or severe attachment issue.
Physically, infants with failure to thrive present with a starkly malnourished appearance and a very distinct, wide-eyed, withdrawn gaze. But it's the behavioral manifestation that is the true hallmark for your exam.
Right. Infants with non-organic failure to thrive often show absolutely no fear of strangers. Now, to a layperson or a brand new nursing student, that sounds like a good thing. You walk into the room and think, oh, what a friendly, easygoing baby. Anyone can hold them. But why is that actually a terrifying clinical observation?
Because it completely violates the timeline of typical infant development. Right around 6 to 8 months of age, a healthy baby develops stranger anxiety. It's a profound, necessary survival mechanism.
Oh, right.
They've learned that one specific person, their primary caregiver, is their safe haven, their source of food and comfort. Everyone else is a potential threat.
So if an 8-month-old baby doesn't care who's holding them, it means that essential psychological bond was never formed. They haven't formed a secure attachment to anyone.
Sadly, yes.
Their psychosocial development is fundamentally stalled because they've learned that everyone is equally familiar and, sadly, equally unreliable. It is a vital clinical observation.
The last major psychosocial milestone we need to cover before we wrap up is autism spectrum disorder, or ASD. Specifically, a major red flag on the exam is a concept called autism regression.
This is heartbreaking, but crucial to spot. Autism regression is when a child literally loses previously acquired developmental milestones, specifically in language or social skills. And the timing is highly testable. It typically occurs between 15 to 30 months of age.
This isn't a child who is just a little slow to start speaking. This is a child who, at 12 months, is babbling, making bright eye contact, pointing at toys, and playing peekaboo.
Right.
And then somewhere around 18 months, a door seems to close. They stop responding to their own name. They lose the vocabulary words they had perfectly learned. They stop making eye contact.
Recognizing that regression early is absolutely critical because the nurse's priority here is to make the appropriate referrals for early intervention therapies.
Exactly. The data is incredibly clear. The earlier the intervention in ASD, the better the long-term neurodevelopmental outcomes for the child. You have to catch the regression the moment it starts.
Wow. Okay, we have covered a massive amount of ground today, tracking the vulnerabilities of a child from the NICU, through the trauma bays of the ER, all the way to their psychosocial environment. Let's wrap up the absolute core takeaways you need to hold in your brain for this ATI exam.
First, when dealing with myelomeningocele, protect the exposed sac, keep the infant in a strict prone position, and keep the dressing moist with 0.9% sodium chloride. If it dries out, do not pull it off, just add more saline.
Second, map out the cascade of respiratory distress. Early signs are fast, sweaty, and restless as the body fights think tachypnea and tachycardia. Late signs mean the heart is giving up. They're slow, quiet, and blue. Bradyemia and cyanosis.
Third, memorize your specific poison antidotes. It's N-acetylcysteine for Tylenol and the molecular sponge of activated charcoal for aspirin. And absolutely, under no circumstances do you use syrup of ipecac to induce vomiting.
Finally, recognize the undeniable physical markers of abuse spiral fractures, from forceful twisting, glove-like burns from forced immersion, and stories that defy the laws of physics. Document objectively, report immediately to protective services.
If you look closely, these aren't just random facts to memorize on flashcards. They're the intricate mechanisms of how pediatric bodies and minds respond to extreme crisis.
So what does this all mean? It means you now have the tools to navigate the diagnostic muddy waters. Mastering these 3 chapters isn't just about passing the ATI Proctored exam, though with this knowledge, you are absolutely going to crush it.
Oh, for sure.
It's about becoming a sharp, intuitive, life-saving pediatric nurse. You're literally learning to read the language of patients who are too small, too scared, or too sick to speak for themselves.
You're learning how to be their ultimate safety net.
Exactly. But I want to leave you with one final forward-looking thought before you go back to your textbooks. The sources we reviewed today show us how to spot autism regression at 15 months, or how to reactively treat respiratory distress syndrome with surfactant right at birth.
All right, which is
Yeah.
reactive.
Yeah, but imagine a future, maybe a decade from now, where pediatric nursing integrates advanced genetic and psychosocial predictive algorithms. A future where we don't just react to a crisis like a sudden airway obstruction or severe failure to thrive, but where we can actually map out and neutralize both physiological and psychological risks before the infant ever even leaves the hospital.
That would be incredible.
How will that incredible technology shift your role as a pediatric nurse, from being a reactive first responder to becoming a proactive, lifelong health architect?
It's a massive paradigm shift.
Yeah.
You'd be moving from treating the symptoms of today to designing the very foundation of a child's entire life tomorrow.
It really is a beautiful thought. To the nursing student listening to this deep dive right now, take a deep breath. You've got this. We warmly wish you the absolute best of luck on your ATI RN pediatric nursing exam. Keep your clinical vision sharp, trust your training, and remember that sometimes the most important diagnostic tool in the entire hospital is simply a nurse paying close attention to a changing story.